the arteries where we are lacking. We are also lacking in the venules. Now, you have those lasers coming in and taking out the leaves from there, as we showed in the laser section. But the reality is that we are not doing enough peripheral work that needs to be done. And a lot of our patients, especially our female patients with DVT and etc., and venous thrombosis coming up and varicose veins, we are not tackling them at all. So the whole wholesome idea about what needs to be done is highly needed. And I request that the Pakistan Cardiac Society should get together in a reality manner and look into this matter very carefully. I understand you have a meeting at 7 o'clock. Do think about it. Thank you.
Just one quick comment. I know, I'm sorry, I'm not part of this session, but I wanted to say it is very important. But this is Bashir Hani, by the way, from Karachi. I couldn't come.
We know you so very well.
So it is very important that we need to have an appropriate training before we embark in this field. The problem is, unfortunately, it's not like same as coronary, and a lot of times we think it is.
We have lost your link. We have lost your link.
Okay, sir. Any comments from the chair?
I think he's talking about the fact that we are not going through the proper training. That is why I'm saying that the Pakistan Society of Interventional Cardiology and Pakistan Cardiac Society need to get their heads together and work on it so that tomorrow we can do a better job.
Same as coronary, and we can just affiliate. You have to get proper training and.
Okay, sir. Thank you for the insight. Anything from the chair? And sir,
I think I'm done.
Like for the question answer session till late, and if anybody wants to ask any questions, I think we have the senior faculty here, although the speakers have already left. Otherwise, it has been very fascinating and very reassuring as well, because most of the talks actually underlined the important fact that this is one of the field of medicine where we are matching with the rest of the world, and we are doing a lot of good things in our limited resources. Professor Masood Sadiq has highlighted the importance of a new field, which is grown-up congenital heart diseases. And we need more pediatric surgeons and pediatric cardiologists who can take up the burden of adult congenital heart disease. And similarly, it's also very heartening to know that people are taking interest in neglected areas of peripheral vascular disease. We will need a lot more number of persons in there. But if you look at the development of our specialties in Pakistan, we must be very realistic that you need to have opportunities for these youngsters who want to come into that field. If we do not have the centers, and if we do not have the incentives, the people from cardiology can do these things on ad hoc basis, but we need to develop these specialties independently. And for that, we all need to make efforts and make these fields practical for those youngsters who want to join them. There may be a lot of enthusiasm. There was a time in cardiac surgery when people thought that while working in a unit of general surgery, they would develop a cardiac surgery setup. It failed. Cardiac surgery and cardiology flourished after having independent cardiac centers. Similarly, pediatric cardiac surgery and pediatric cardiology flourished after having independent children's heart centers. And if we wish to have these vascular fields also grow, then we will need to have centers for that and specialization in that particular area. I'm extremely thankful that you provided me this opportunity to be part of these sessions. And it was interesting. And there were a lot of things to learn from all of these new developments. Thank you very much.
I think in the interest of time, I'm just going to say thank you to all the speakers and let Dr. Asim take the mic.
Okay, thank you so much. This concludes this session. I will be introducing the moderator for our next session, the 5th session on 2nd day, Professor Dr. Asim Javed. I would request him to come on, sir. Okay, sir. Okay, sir. Kindly take over.
Bismillah ar-Rahman ar-Rahim.
Thank you very much for continuing to sit here. So let me invite my panelists quickly. I'll request Professor Anjum Jalal to continue sitting here. He's the backbone. He's the support that we have at RIC, and with his blessing and support, we've converted the stroke program into a 24/7 program. We've got TPA, mechanical thrombectomy, everything available. Let me invite my mentor, Professor Suhail Aziz, onto the stage. He's the one from whom I have learned so much, and I think he has a big contribution in my career and where I am today. Let me also have the honor of inviting Professor Rafizullah onto the stage. So we'll be very honored if you come onto the stage, please. And I can also invite Dr. Siddiqui, if you can join us onto the stage, sir. Professor Rafizullah, can I request you to kindly introduce our international faculty, please?
We have this session is co-sponsored by American College of Cardiology, and I as a governor of ACC chapter Pakistan, I would like to welcome Dr. Salim Virani. Salim Virani is a very well-known figure in cardiology. He is a professor of medicine cardiology in Baylor College of Medicine, Houston. Besides that, he also works in Michael DeBakey Veteran of Affairs Medical Center. But most of us know him because of his NCD Academy, in which he has worked very hard to establish that NCD Academy under ACC, and he has worked very hard in ACC, very well-known figure in preventive cardiology. So I'm sorry we kept you waiting, but there were things, you know, these cardiologists, they keep on talking and talking, and they could not stop. That's the reason. I'm sorry for that. So Dr. Salim Virani.
So before the talk starts, let me also introduce Dr. Bashir Hanif. I hope he's online. He's the Executive Director of Taba Heart Institute and past President Pakistan
Yes, I am.
International Society. Okay. So over to Dr. Virani then. Thank you.
Good evening. Assalamu alaikum. I hope all of you are surviving the day. I know it's been a very long day for you. Thank you for the kind introduction. It's good to be actually be here with all the colleagues and all the folks who've been doing some amazing work in Pakistan. So first of all, thank you for doing it. Thank you for all that you do. And I am proud to be one of the Pakistanis who happens to be living in US doing my preventive cardiology related work. Let me share my screen and then we will get started. So again, what I was asked to talk about, and I was given 20 minutes, I'm going to try to stay on time and maybe try to finish a minute or two early. What I was asked to talk about was hypertension and stroke management. Now, of course, as you can imagine, this is a very, very wide area. So I'm going to try to give you some tips based on the ACC AHA guidelines and try to stay within the allotted time that I have. These are my sources of research support as well as other disclosures, none of which are in conflict with the talk today. Stroke and hypertension. The first question anybody would ask, and all of us as cardiologists as well as physicians who are taking care of patients, which question that is being asked is, what are the blood pressure targets in primary stroke prevention? Somebody who has not had a stroke, we all try to deal with in our profession. What are the blood pressure targets in acute ischemic stroke as well as acute hemorrhagic? Try to answer, and I'll show you the guidelines and some of the data behind. The third question that we ask is that what is the blood pressure? Start out with primary prevention of stroke. What do we do in the acute is, okay, we've taken care of the patient in the acute phase. What are the blood pressure targets in secondary stroke prevention? So if we look, as I think you all are aware of, the up, which was that even 120 to 190, 29 elevated blood pressure, and 130 to 139 of systolic became stage 1 hypertension. And of course, this is a very, as well as great clinicians in Pakistan, cardiovascular disease, whether we look at systolic blood pressure or we look at diastolic blood pressure. This is data from 69 prospective studies, very high. See that there's a very strong, when you look at systolic blood pressure with cardiovascular events, it's the same thing, except that now there is data that there's a U-shape associated with a higher mortality, especially in older adults. it's likely a reflection of poor compliance of the vessels. And that, of course, we know is associated with a higher risk of cardiovascular events as well. So that was one thing in terms of association of blood pressure. What happens when this is one of the very large meta-analyses that have tried to treat patients to below 130 millimeters of mercury target. And those are the Accord trials, SPS3 trial, as well as which of course looked at it as well. And when you look at all of these three trials, which was the most recent being the SPRINT trial, what you lead to 10 millimeters of systolic or 5 millimeters of diastolic pressure, coronary heart disease, heart failure events, as well as stroke. But you would think that it would lead to an equal those endpoints, but what you'll see is that for stroke, in terms of prevention, much stronger association. In fact, if you look at you again will find the same in terms of reduction of events in prime, at least as strong as CHD, if not more strong. Now, the other thing I wanted you to look at is this very large analyses are where you can compare various therapies or various therapies that lead to various impacts. So here, when you look at this group of those who attained a blood pressure 120 to 120, even 125 to 129 attained systolic blood pressure in events for those systolic blood pressure in these trials. That's not the only thing. 24 to more than one trials, you look at the relative risk reduction 30 or 134. So what it's telling you is that pressure in these clinical trials, the more the benefit. And doesn't matter if in sensitivity analyses, you take out SPRINT trial, you basically take out other trials, the results were very, very consistent. And the same holds true for stroke, CHD, and all-cause mortality when you look at them separately. So based on all of this, the ACC guidelines, when they came out in 2017, came up with a treatment target for primary prevention of stroke and any other cardiovascular disease to be less than 130 over 80. So that was the first part of the talk. What are the treatment targets for patients for primary stroke prevention? Now let's switch gears and talk a little bit about the management of acute hemorrhagic stroke. What do we do with these patients? And again, this is acute management, not chronic management, where the same goals would apply. So let's talk about acute management. And what we know is that if systolic blood pressure is more than 220, we have enough evidence, mostly from observational data and small RCTs, that if we lower blood pressure in those patients, it's associated with improvement in outcomes. So it's a 2A recommendation, something that can be considered. And the reason for that is that if somebody has acute intracranial hemorrhage, if we don't treat very high blood pressures, it leads to hematoma expansion. And that, of course, is associated with poor neurological outcomes as well as poor cardiovascular outcomes 3 to 6 months down the lane. The other thing, though, is that if the systolic blood pressure is 150 to 120, 220, what do we do in those patients? And there, actually, the initial trials showed that it was safe, but the last two trials we have, one of them showed that it could be associated with harm as well. So I'll show you those two trials very quickly. And then what you need to keep in mind is that somebody who comes in with high blood pressure in the setting of intracranial hemorrhage, it may be that they're not hypertensive. It's probably a response to intracranial hemorrhage to maintain cerebral perfusion because of high perfusion pressures that are required in patients with stroke. So be very mindful of treating these patients. And in fact, I'll show you some data that there may be harm associated with that. So the first two studies we had were INTERACT and ATAC, and both of them showed that it was safe to lower blood pressure in those patients, although we didn't have enough in terms of outcomes. But then now we have two trials. One is INTERACT-2, which was done in patients with intracerebral hemorrhage. And this was published in New England in 2013, done in 20 countries, where they looked at intensive blood pressure lowering versus blood pressure lowering to less than 180. And again, their primary outcome was death or major disability in these patients. And then secondary outcome was just looking at modified Rankin scale, again, in terms of the stroke related outcomes on an ordinal scale of 1 to 3, 3 to 6. And what you will see here is that overall, the primary endpoint was not met. It was borderline significant, but those of you who are clinical trialists would say that this is not significant. On the ordinal scale, it seemed like it was significant. Again, just meeting treatment threshold. But as you will know, again, if the primary endpoint is not met, there's not much in terms of looking at secondary endpoint. Then we look at ATAC-2 trial, which again looked at aggressive blood pressure, intensive blood pressure lowering in these patients with intracerebral hemorrhage. And what you will see again is that when these patients were looked at, the primary endpoint wasn't met, hematoma expansion-related endpoint wasn't met, as well as when you look at renal events, there was actually a signal towards harm in these patients. And that's why it's recommended now that we do not lower blood pressure unless it is above 220 systolic in those patients with acute hemorrhagic stroke. Now, switching gears and talking about ischemic stroke patients. What do we do with patients who are presenting with acute ischemic stroke in terms of blood pressure lowering? There are two scenarios that I would discuss here with you very briefly where we do need to lower blood pressure, and that is in patients whom we are giving TPA, and primarily none of those patients were enrolled if their systolic was above 185 or diastolic was above 110. So we need to do that because that's a criteria to actually be given thrombolytics in those patients. So that's number one. And then once you have given thrombolytics, we need to maintain systolic below 180 and diastolic below 105, because we know that in patients who've received thrombolytics and the systolics or diastolics are very high, the risk of having intracranial hemorrhage goes up exponentially if the blood pressure is not lowered. So that would be one group of patients where we would lower blood pressure. The second group is this very difficult group of patients who again present with acute ischemic stroke but have very high blood pressure and do not have a history of hypertension in the past. And again, not very clear why the blood pressure may be high, but we all know that again, any ischemic stroke leads to increase in blood pressure. To maintain that cerebral perfusion, especially in the penumbra of acute ischemic stroke, where we know the auto-regulation of blood pressure is very deranged. But at the same time, if the blood pressure is too high, then it increases the risk of cerebral edema in acute ischemic stroke, as well as hemorrhagic conversion of acute ischemic stroke. So in those who have a blood pressure that's very high, above 220 systolic or above 110 diastolic, in those patients, blood pressure lowering is recommended, but we have to be very slow and not lower more than 15% in the first 24 hours. So we maintain that balance between a deranged autoregulation, which requires us to maintain a high perfusion pressure, but at the same time, we do not lower it too much that the perfusion is impaired in that ischemic area that is surrounding the main infarcted tissue. So that would be the recommendation. It's a 2B recommendation. And the way I talk to our residents and fellows, may talk about 2B recommendation, something that may be considered. So it's a 2B or not to be. So be very mindful of that and be very careful in those patients not to lower the blood pressure too acutely. Now, what do we do in this category of less than 210 or less than 110 diastolic? And there, what we know is that lowering it acutely in the first 24 to 72 hours is not associated with much of a benefit. But if somebody has pre-existing hypertension, then in about 24 hours, when the neurological status has stabilized, then we can start the medications. And why is that we don't treat acute blood pressure in these patients? We do not know if they're hypertensive or whether there is a response to hypertension. And then even treating it, when we look at major studies, has actually not shown any benefit. This is one of the very large meta-analysis that was performed. And when we look at long-term or short-term dependency in patients with ischemic stroke who are aggressively treated, there was no benefit. Similarly, when we look at short or long-term mortality, there was no benefit in treating those patients. So again, the message is, if patients have history of hypertension and they have high blood pressure, once their neurological status has stabilized in 24 to 48 hours, go ahead and treat them. Otherwise, just make sure that this is undiagnosed hypertension that we are treating, but not a response to ischemic stroke that we are treating. How about after the first 72 hours? When patients have hypertension, of course, if somebody has history of hypertension, restart their medications and aim for a blood pressure less than 130/80, which is a 2B recommendation here. But what if they do not have history of hypertension? Again, if their blood pressure remains above 140 or 90, go ahead and start the treatment and aim for a blood pressure of less than 130 over 80. But if their blood pressure is between 130 and 140, we really don't know what to do with those patients. It's more of a 2B recommendation to treat them below 130 systolic. So again, the message in acute ischemic stroke is wait a little bit, but then go ahead and treat them and try to target less than 130 over 80 in those patients. What about long-term treatment of patients with stroke to prevent recurrent stroke or recurrent cardiovascular disease events? And there again, we have a ton of data that aggressively treating those patients reduces the risk of recurrent stroke, as shown again in this very large and very well done meta-analysis, and also reduces recurrent CVD events. So I think if I had to provide take-home messages, primary stroke prevention, just like prevention of MI, do very aggressive hypertension management. Try to treat those patients to below 130/80, which is a better target than even 140. And I know there is some divergence of opinion as far as European and American guidelines are concerned, but I think there's enough data there to support it. When you have acute stroke, go slow. Unless you have more than 220 millimeters of mercury in the setting of acute intracerebral hemorrhage. If you're giving TPA, then aggressively lower blood pressure, not too aggressively, but definitely lower below 185 and 110 to give TPA, and then maintain a lower blood pressure to avoid hemorrhagic transformation. In acute ischemic CVA, only treat if your systolic is above 220 or diastolic is above 110 in the acute setting. After 48 to 72 hours, try to go below 140/80, and definitely after 72 hours, try to treat your blood pressure with a target of less than 130/80 to reduce the risk of recurrent events. So again, we have to be careful in the acute setting, but in primary prevention and secondary prevention of stroke, we have to be very, very aggressive. And I know I covered a lot of topics, but I hope that this made all sense to you. And again, I'll stop by saying that, the secret to living well and longer is eat half, walk double, laugh triple, and love without measure. I mentioned this to make sure that we are also working on lifestyle adaptations, which of course I didn't have much time to cover. But I'll stop here and see if the session chairs or moderators or any of our attendees have any questions that I can try to answer for you. So thanks again for inviting me, and I'll take any questions.
Thank you very much, Dr. Virani. It was a beautiful talk. And I know people have so many questions to ask on this subject. But just in the interest of time, we've got 2 more talks to go. So we'll go ahead with the 2 talks. And then at the end, we'll have all the questions. It gives me immense pleasure now to invite and introduce Professor Umar Göktaken from Turkey. I don't know how to start introducing him because he's a wonderful person with so much skills. And the beauty is that he achieves excellence in whatever he does. So he's an electrophysiologist to start with, then an interventional cardiologist, and he achieves excellence in CTOs. He does TAVR, he does EVAR, TVARs, and he does stroke interventions. So I think mitral clips as well. So everything from head to toe that you can think of. And as I said, he achieves excellence in whatever he does. I really apologize from Professor Umar Göktaken for all the delay that we had. Thank you, Dr. Umar Göktaken, for your patience and joining us. And over to you for your talk on role of interventional cardiologist in acute stroke management.
Thank you. Thank you very much. Thank you so much for your introduction. Bashir, I forget that I am an electrophysiologist some time ago, but you still remember it. Last, I think, 8 years, I don't do any more EP ablation on other things. I give up actually for electrophysiology, but others, yes, I try to do in my practice. Thank you very much. I'd like to share with you acute stroke intervention and what's the role of interventional cardiologists in acute stroke management. I believe that you mentioned the scope of the problem. Stroke is really a big problem for us. about 1 in 5 women and 1 in 6 men will suffer a stroke in their lifetime. So this is very important topic. I think we should treat. We should discuss more. This is a very big problem for everyone. So time is brain, like time is muscle in the myocardium. It's very similar concept. We can save the penumbra. We can save some millions of neurons if we do intervention in acute stroke patients. What is the penumbra? Penumbra is a zone of reversible ischemia around the core of irreversible infarction, salvageable in first few hours after ischemic stroke onset. You know, after acute occlusion, there is a core. It's already infarcted. We can't do anything about it. But we have also penumbra. We can save those area. If we don't do anything, if the vessel remain occluded, we will lose also this area. So we can save this if we do timely intervention. So endovascular treatment in patients with ischemic stroke should be preferred because IV thrombolytic therapy has narrow therapeutic window, low recognition rates, high complication rates, and 15% of the mortality. Fortunately, we have 5 major trials evaluating the role of endovascular therapy in stroke management, and all of them stopped because of the significant benefits in the endovascular arms. Also, these trials show that large vessel occlusion should be targeted. This is very important. And also, stroke intervention is safe. Modern clot retrievers are effective. Although only 5 of the patients had modern therapy in these trials. So we have better device now in our shelf. What these trials are different than before, because at the beginning we have some negative trials regarding acute stroke intervention. There are 2 main differences. The first one is these 5 large trials confirmed that we have a large vessel occlusion, so it's an indication for endovascular treatments, and also those recent trials also done by retrievable stents, which is most of them were solitary in those patients. Anyhow, what is the stroke treatment in our era now? If the patient came first 4.5 hours, which is early time, and if NIHS score is higher than 6 or lower than 6 with aphasia, and also there is no large early ischemic signs of CT. If we have a big ischemic signs in the CT, I don't think recognition will help a lot. And also we have to show that there is proximal arterial occlusion on CTA. So it's important, of course, to see we have a large arterial occlusion like distal ICA, middle cerebral artery 1 or anterior cerebral artery A1. If we have a patient in 4.5 hours, then we can start intravascular intravenous TPA, and also we will send the patient to cath lab to have intervention. Or if a patient came to us after 4.5 hours to 8 hours, and again, if NIHS score is higher than 6, and also there is no large ischemic signs of this CT, aspect score should be higher than 6. Yes. And of course, we have to have also proximal arterial occlusion on CTA. In that time, we don't do intravenous TPA thrombolysis, and we directly have the patient in cath lab. So the difference if the patient have after 4.5 hours, we don't do intravenous thrombolysis. If we have patients even late, like after 8 hours, in that time, again, we shouldn't have a large ischemic signs on CTE. Aspect score should be larger than 6. Of course, you have to have proximal arterial occlusion on CTA as before, and also we need to have multimodal imaging, and those imaging should show us there is still salvageable tissues, because sometimes patients may have collaterals, and that those collaterals make those area live. So if we see, if our multimodal imaging shows us there is salvageable tissue, then we can do intervention, although patient came in late. So this is also important, and it's shown by many studies we could help if the patient came late. So what is the endovascular target parameters? So we have to have good neuroimaging at aspects for aspect scores has to have bigger than 6. We have to have confirmation of major vessel occlusion, very important. It's good to have good collaterals. And this is also important, like coronary, neuroimaging to femoral puncture time should be less than 6 minutes, 60 minutes. Time is extremely important. And femoral puncture to recognition time should be less than 30 minutes. Okay, who should do acute stroke intervention? Since there are lots of patients to be treated, I don't think in the world, in our country, in any country, there is enough interventionalists to do all these patients, right? So I think I don't think number is enough. I don't think interventional neurologists numbers are enough. I think in many countries, like in my country, I think cardiologists also should be involved in this procedure if it is possible, if the system is allowed, of course. What's the advantages of the cardiologist? Of course, we have capable of intervention procedures. We already do lots of carotid stenting in our lab. So we know how can we access the carotid artery, which is, I think, the most important part of this procedure. There is a same logic with the acute coronary intervention. We have to be hurry, we have to be, timely, and we have to be very careful, of course. So dynamic management is important. Also, etiological management for stroke is related with the cardiology, since 30% of the patients has cardioembolic source. Of course, we have some disadvantages. Obviously, the number one is we are cardiologists. We have lack of knowledge of neurovascular anatomy. We should learn it. We should learn some basic neurological examination, maybe, and also if we really interest this procedure, this business, I think we have to have advanced basic stroke pathophysiology and complications. I think training will solve this problem especially for the young interventional cardiologists. Of course, we are aware of the difference in cerebral artery. Vessels are extremely fragile. There is no medial layer, so it's very easy to have rupture in cerebral artery. We have to be extremely careful. It's not like coronary artery. So in stroke team, what we have in our hospital, emergency physician is involved in the stroke team. We have neurologists, we have stroke physician, we have radiologists, we have interventional neurologists, and also interventional cardiologists in our team. So in our hospital, we have some neurologists who can do also intervention, so we work together. We do cases together. In terms of stroke pathway, there is pre-hospital evaluation in the ambulance. If the ambulance thinks that the patient has acute stroke, so they call the hospital. They said that they are bringing a stroke patient, and a patient has been seen in the emergency department. If it is real stroke, patient goes to directly CT, and if the CT shows no acute hemorrhage, and if the CT angio shows us there is a large vessel occlusion, patient goes to directly cath lab. So once we have acute stroke patients in emergency department, they call us first to prepare cath lab for the possible intervention. Sometimes they have small artery, very small distal artery. In that time, they do thrombolysis. Sometimes patients has nothing. Sometimes patient has, of course, acute hemorrhage. But we keep the lab ready because I think it's more important than acute. But once CT angio shows the acute occlusion, we have the patient in 10 minutes. So aim of the endovascular treatment is, of course, to have effective and fast recanalization. It's nice to have TC2B or 3 or modified TC2. We have to be very careful. We might have rupture, we might have dissection or distal embolization. In terms of endovascular techniques, we have stent retriever, we have adult technique, we have combined strategies, we have also adjuvant treatments, angioplasty. Carotid or for the posterior circulation vertebral access. For those who do carotid intervention, I don't think this is an issue. Of course, someone who would like to do acute stroke intervention, first of all,
एक्सक्यूज मी, मैं उनसे पूछें कि ये इशू कहाँ पर आ रहा है। उनके एंड पे हमारे एंड पे।
Okay, I think there's some technical problem going on and it will take a minute or two to settle. Just to add on to what Umar Goktekan was saying, we must realize that the number of neurointerventionists all over the world is not enough. So even in developed countries like United States, Germany, South Africa, Czech Republic, there are many other countries, Slovakia and all, where interventional cardiologists are actually part of the stroke team, and they are performing stroke interventionists. So any burning questions up till now, I would be happy to answer, or maybe if Dr. Virani is online, we can take some questions regarding hypertension and stroke management till Dr. Umar Goktekan is back online. Yes, please, Dr. Wahid. Can we have the mic, please? Is Dr. Virani still with us?
Asim, while we're answering, waiting for others, how are you reconciled with the neurointerventionists, the interventional radiologists, and the neurointerventionists, how you reconciled with them. Some are very, not very happy with the idea of cardiologists joining in. And how is your the relationship with those guys going on nowadays? What's the latest?
Sir. So it was a turbulent course to start with. And I must say I was very lucky to have backing of General Azhar Kiani. And he was the key factor who kept supporting, and we were able to somehow continue with our program despite of all the opposition. But I think with the passage of time, neurologists started realizing that what we were doing was not something against their interest, because we have a neurologist on board who's full-time employed with us. He's the one who does all the case selection. The only part that we play is the part in the cath lab. So he does the case selection, he does all the management pre and post intervention. So we have a neurologist on board, we have neurosurgical backup going on. So initially we didn't have any referrals from neurology, but now I think they have sort of reconciled with the fact that cardiology is there, because neurology will take time for themselves to come up and start this intervention. We'll be very happy for them to take over. But I think if countries like United States and Germany and all those places who are so advanced, if they need interventional cardiologists on board, Pakistan can be no different. But I think we are now in a very comfortable position with neurologists.
I think probably same is true for, as you said, in States and Europe as well, that they do not have that rare breed called interventional neurologist. And even the programs are so rare in America. There are hardly 15 to 20 programs. And then they take neurologists, train them for 2 years. So it's such a long learning curve that by and large people, then again, neurologists are not used to the lifestyle of waking up at night and rushing to the hospital. So it's still a very unattractive field for them. And I think perhaps for that reason, cardiologists have to probably just plug it.
There's another aspect.
Well, I can tell you that in Karachi, can I say something, sir?
Yeah, of course.
Actually, in Karachi, can you hear me?
Yeah, of course we can.
Yeah, in Karachi,
Go ahead, Dr.
most of the
Bashir.
neurology, I'm saying that in Karachi, I spoke to all the neurologists, major neurologists in the city, and none of them had any problem. And I told them, so I think Dr. Goptigan is probably back, so maybe we can have him and I can say something later on.
I apologize. I don't know, but I lost you. I was talking about two technical considerations. I tried to say that we can use. Can you hear me now?
We can hear you, but we don't see your slides, Dr. Goptigan.
Why? I already share them.
Yes, now your slides are there. Yeah, please go ahead. We have your slides.
Okay, so for the technical considerations, of course, we have to do, before we start acute stroke intervention, we have to do at least 50 carotid stenting, to learn how can we access carotids, right? This is very important. We have to access carotid artery easily. And also, we have to learn the techniques. Yes, we have basically two techniques for carotid access. And also, I like to tell you that, and I like to mention that we have to use balloon-guided catheters when we do acute stroke intervention to reduce distal embolization. And we have a NASA registry show that if we use balloon-guided catheters, our chance of have higher TC3 flow is much better. You see, if we use balloon guide, we have 53% TC3 revascularization. If not, we have 32, and its p-values is very good. And this is balloon guided catheters. We have many types in the market. Mostly we use cello, 8 French, and also we have MoMA for carotid stenting. We have exchange technique. Some people do that. We use always telescopic approach. For the exchange technique, we just send a catheter. This could be left diagnostic, this could be right diagnostic, or SIM catheter. If we deal with the left system, left carotid, we always use SIM catheter to engage it. But for the right carotid artery, we can use either right catheter or right diagnostic catheter. After access, for example, right carotid artery, we send the wire up to the external carotid artery, and then we send diagnostic catheter up to external carotid artery, and then we remove our wire, workhorse wire, with the stiff wire. It could be amplatz, it could be supracore, but we insert stiff wire to send sheath or balloon guiding. And we have also telescopic approach, which we use routinely in our lab. In that time, we use balloon guided catheters or guiding sheath, and we have also, a diagnostic catheter inside it. So you see that this is the wire. We insert diagnostic catheter, and over that diagnostic catheter, we insert the sheath. This is the telescopic approach. We do this technique all for carotid artery and also for acute stroke intervention. This is also faster than exchange technique. And I'd like to show you one cartoon here. We have basically two techniques. One is stent retriever technique. For that, we will cross with the wire. We insert the microcatheter. We cross the plug with the microcatheter, and we insert the solitaire or any stent retriever. You see this here. Very important to use balloon guidings. Why? When we are pulling, we might have some distal embolization easily. If we have occluded proximal artery, we will know any more distal embolization. This is extremely important for acute stroke intervention, and I think it should be routine now. Another technique is aspiration. To do aspiration, technique is similar. We cross the lesion with the wire and microcatheter. We park the microcatheter here, and up to here, we insert distal access catheter. We call it back catheter, distal access catheter. And also we remove wire and microcatheter, and after that, we can do also manual aspiration. That's also, we can do, but we have automatic aspiration. We call it penumbra aspiration. Very nicely, we can take the clot out, as you see here. And now, at the moment, in many labs, do the same use the same technique together. They use stent retriever, also aspiration. But to be honest with you, it will be more costly if we use both of them. What we do in our practice, we definitely use balloon guiding catheter, and we do manual aspiration with 50 ml syringe, rather than to use automatic system, which is more expensive. I'd like to show you one example for mid-cerebral artery occlusion. So we send, this is DSA showed us, this is anterior cerebral artery, this is middle cerebral artery. We have occlusion just at the proximal of the middle cerebral artery. And as you see, we have lots of, empty, there is no flow here at all. We have some collaterals, you see, comes from the anterior cerebral artery, but of course it's not enough. So we have to do something to this patient. Basically, we send a wire through that clot, I'll show you which kind of wire we will use. This is O14 wires. We'll send it to distal. Most of the time, it's not an issue to cross because the thrombus is very soft. And after that, after crossing with the wire, we insert microcatheter, as you see here. And also we can use, sometimes we use distal access catheter to have better support and to manual aspiration. After inserting microcatheter, you see we have lots of type of guide wire. These guide wires belongs to neurovascular companies. In some country, it may not easy to reach them, but as cardiologists, we have also good wires. All of them, all of you knows about them. I know it. Mr. Low Spot can be used very successfully. We can use BMW. We can use also Asahi Regalia. Also, we have Asahi Chikai Black in our market. I don't know if you have it.
Ajo.
Hello? Hello?
Yeah, we can hear you, Dr. Kumar.
Yes, we can hear you. We can hear you.
Okay, thank you. Yeah, okay. So, of course, we have to be very careful. We can easily rupture the vessels. We have to have J-shape. One, we shouldn't go with the looped. This is also important. We have to be careful in cavernous segment. We have to be very gentle. We have small side branches there. And also, we shouldn't push. If we feel any resistance, we never push. In coronary, sometimes if we have a resistance, we push it to have, knuckle to go easily to distal. But in cerebral artery, we never do that. And we have several type of microcatheters. We can use Rebar, for example. We have Rebar in our lab, and mostly we use Rebar. We have 18 and 21 in our lab. Have the acro one, which is Trevo, and we have lots of other type. I don't think we can have all of them. I think we have to have it's enough if we can reach one or two of this microcatheter. We cannot have all of them. We have to choose at the beginning, and we have to learn how to use them. And this is stent levers. We have Solitaire. This is, I think, the first one. We have Trevo, Catch Maxi, Preset, Aperio, Eric, and Tiger. And we have more. There are lots of others coming. And if we go back to our patients, now we inserted the stent lever here, which is Trevo in this patient. We just unsheath the stent lever. In that time, we open the stent lever like this. Now we hope that it's catch the thrombus at this level. We wait 3 to 5 minutes. Mostly they say that 3 minutes is enough, and then we pull wire, we pull microcatheter and also stent lever together while somebody do aspiration. This is important. You see while we are pulling in it, this is stent lever. We pull gently. I hope you see it. I don't know if the quality is good enough to see that. We remove it now. You see we have balloon guiding here. Very important again. And after aspiration and stent retrieval, we see very nice flow. We have excellent distal flow. If we have patient in good time, most of the time we have very good result. In some patients can start to talk in the cath lab. They can start move their arm or their leg in the table. It's like miracle. This is very, very nice, and for us, I think the most awarded job to do, to be honest. To see people is, starting talking, starting moving is extremely nice. So we can do microcatheter contrast injection after cross the clot to see the distal. We can do that. It's better to do stent retriever deployment more in the clot. It's important, and also we have to wait some time. And it's better to do under aspiration and steady aspiration. And also, it's better to use longer stent retriever than short one. And also, there is a technique. Martin Wiesman described that while we open the stent retriever, we have to push the stent retriever catheter a little bit to have better catchment. They said. So we do that. We do this routinely now after this paper. And also, we use longer stent retrievers than shorter one. So there is another technique combined, which is stent retriever, also penumbra technique. I'd like to show you an example for that. Again, we send a wire, and over that wire we use sheath, and this is duct catheter, distal access catheter. If we do penumbra, we have to use distal access catheter. Now, both aspiration and retriever. This is, of course, most effective technique, right? So most of the time, at the first passage, you have nice, clean artery if you use both of them. In terms of technique, it's not that difficult, but of course, we should learn, how to do. We should learn, most importantly, how to avoid the complication. This is, I think, the number one thing. Again, distal access catheter here and stent retriever. So what we do both retriever and also aspiration. It's very easy if you deplate the stent retriever here first. Very easy to push distal access catheter. Those catheters are extremely soft, very different than we use in our lab. So we have to know that they are very soft. The catheter, they are 5 French, 6 French, but they are extremely soft. So those techniques called Solumbra. Advantages is no need to pass the lesion again, and we can do contrast from duct catheter. Distal embolization and carotid embolization still could be an issue, of course. Be careful for the backup. Another left system intervention. It looks that it's not difficult. It's not easy to cross the lesion, but it's really easy. Crossing the lesion is easy. Inserting the microcatheter is easy. In terms of technique, this procedure is not that difficult, I have to say. Neuroradiologist doesn't like it when I say it, but it's true. It's not that difficult work to do, to be honest. But we have to know, how to avoid complication. I think this is very important part. And now we are pulling against stent retriever. We have, you see, balloon guided catheter. This is very important. We have to use those. Otherwise, we might have distal embolization, and our result may not be perfect. Very nice feeling now. I think in any country, patients should be treated in that technique, in that procedure, and governments should take care of this procedure, I believe. So, yes, I'd like to stop now. I hope you could heard me, and I don't know, I have some difficulties. Somehow I didn't understand what happened, but I hope you follow my slides. Thank you very much for your invitation. I'm very happy to be with you today. Thank you very much.
Dr. Umar, this is Dr. Asim Javed from Rawalpindi Institute of Cardiology moderating the session. Thank you very much for always supporting our stroke initiative and program in Pakistan. In the interest of time, we'll keep question answers for the end. Now we're going to share two cases from Rawalpindi Institute of Cardiology, and I would like to invite Dr. Hamza Gauri, consultant cardiologist, Rawalpindi Institute of Cardiology.
Bismillah ar-Rahman ar-Rahim. Thank you very much, first of all, for giving me this opportunity today. It is indeed a matter of great honor for me to be a part of this annual update of cardiology, which is held at Bhurban, and more so to be amidst such stalwarts and masters in the field of cardiology and cardiac surgery. So today, I'm going to present two cases of stroke intervention that we performed at Rawalpindi Institute of Cardiology. So I start with the first case. So this is a 50-year-old lady who's a known diabetic who presented in the ER of Rawalpindi Institute of Cardiology. And on presentation, she had weakness of left side and difficulty in speaking for 4 hours. On examination, the power on the left side in the upper limb was 0/5. The left lower limb showed a power of 1/5. There was a sensory loss, dysarthria, and left upgoing plantar. At this juncture, the neurological examination was completed, and the NIHS score, which has been discussed in detail, which shows the extent of neurological damage, was done. And it turned out to be 12. And we know that less than 5 is minor stroke, 5 to 15 is moderate stroke, and above 20 it becomes severe. So with this, the patient was then shifted to the CT scan room where we had to beat the time. And the door to CT time rather has to be kept within 20 minutes as per AHA and ESO, which is the European Stroke Organization Society, which has made it clear in their recommendations. So we try to meet that as we have other guidelines to meet as well. Now this CT scan was done, and this is an axial view that you can see here. So initially, we look for intracerebral bleed. We have to rule that out. We have to look for any infarcted area. But in this view, we were unable to pick any infarct. So initially, in 12 to 24 hours, we may not see any infarcted area. But at this juncture, where our neurologist as well as the radiologist are on board, this is where we have to decide whether the patient who qualifies for thrombolysis, which is TPA, should get TPA if they are presenting within 4.5 hours window. And this patient did qualify for that, and TPA was started. So I'm going to get into the detail of how the TPA is given, and we'll talk about that in the subsequent slides. So after that, we go for a CT angiogram, and these are the images. You can see this one here, that this is the axial view. The sagittal and coronal views are lined up as well. This one is the coronal and the sagittal views. So I'm going to take you to the area of interest straight away. So what we have here is the finding that you can see here. Your MCA, middle cerebral artery, on the right side is occluded at the M1 level. And we know that there are 4 levels of these vessels. So M1 is the large vessel, which goes up into the M2, moderate, M3, and then M4, which are the smaller vessels at the periphery. Now, you see that this again shows you in the sagittal and coronal views. Now, I move further, that now we have established the stroke already. We also have done the cerebral angiogram, which not only tells us about the blood supply of the brain, but it also allows us to plan our intervention accordingly, because the view is taken from the vertex to the arch. Now we can plan it accordingly in terms of our axis as well, and we will show you in the subsequent slides how we did that. Now the treatment was started, as I've already mentioned, that TPA was given, so 0.9 milligram per kg body weight IV is given. And the maximum dose that we can go up to is 90 milligrams. So 10% of that was given as a bolus over 1 to 2 minutes. And this was given on table once the CT scan was done. And then the rest was continued IV for an hour. Now this continues the patient who gets shifted to the ER, and maybe there the patient is then moved to our cath lab. And even during the procedure in the cath lab, this is continued during the procedure. So we do not stop it and meet the targets. So next, I would like to show you this picture here, and this goes to, I think okay. So I'll have to come back. And this highlights the team effort that is put into it. So there is an ER team, our neurologists, our radiologists, interventional cardiology team. They're all lined up. Everyone is doing their bit to make it a success. And what you have here is a pit stop in Formula One racing where seconds matter. So it's the seconds which make all the difference. And we already know, as Professor Umar Goktekan has mentioned, and I think Dr. Virani also mentioned, that stroke, in stroke cases, time is of essence. And time is basically brain. So we have to beat that. This is where the team effort comes into play, and we try to meet those targets, like door to CT time, door to needle, which is less than 60, and a door to sheath time, which is 90, ideally less than that. Now, here the patient was then shifted to the cath lab. A right femoral axis with a 6 French sheath was done. A 5 French SIM2 catheter was used. And we've gone through, thanks to Dr. Ruma, for illustrating the techniques to engage the carotids. The cerebral angiogram was done. And I'm just going to show you this slide, which shows you what happened here once we did take the angio. And here you see a DSA. This is the AP cranial view, and we create that by aligning the supraorbital ridge with the petrous part here, and you see this ridge here. Similarly, this is the lateral view where we align both this, although we've got a 10 French sheath, because we have to also at the same time check the pressures. If you go with the same sheath size, it won't be possible. Now, the wire is taken up. You can see here this goes up to the level of middle part of the cervical internal cerebral artery, and we take it above the level of bifurcation. So this is how it's sparked. And then over that, we now create this assembly. This is already mentioned by Dr. Umar, that it's the telescoping of different guide catheters. And how we do it? We have a cello guide, 9 French, with a balloon tip, which goes up, gets parked in almost the middle part of cervical ICA. You have a Sophia Plus, which is the intermediate suction catheter that goes up. You can see that going up here. You have a micro catheter, which is tracking, and then you have this wire, which is 0.014 wire, which is Traxxas wire in this case, which is taken up. So all of this is happening over the wire. And how do we prepare the tip of the wire? Just like a CTO vessel, 1 to 2 mm, we make a bend, but we have to ensure that it's a J loop so that it takes a loop and goes up. Because if we go straight away in, the microvasculature and the vasculatures, particularly even in these large vessels of the brain, the media and their intima is quite thin and may just get through, and we don't want that. So this is what we did. I think we've already seen some wonderful slides by Dr. Umar. So we took the wire up, it's parked up with the loop, you can see this, and we've gone almost till the end of M2. And we take the micro catheter up, you can see this, we've got Sophia down there, and now I'm going to move to the next slide, which shows that the wire, once removed, you have to use the micro catheter to see the extent. And you can easily give through the microcatheter with 3 cc syringe, small puffs. You can see those being given in the AP and the lateral views. And so this is how we assess the distal vessel. What we can do is, if we want to assess the distal as well as the proximal extent and the overall extent of the thrombus, we can use simultaneous injections with a microcatheter and also with Sophia. So that the Sophia is going to tell us about the proximal end of the thrombus, and the microcatheter is going to give us where the distal part of the thrombus is. And we can plan our the strategy accordingly. Now, I move to the technique that was used in this case, and we used the Solumbra technique, and we already know that it's a combination of 2 techniques. So one is to have an aspiration catheter, take it up, and aspirate the thrombus, which is also known as adapt. The other one is to take a stent retriever, which in this case was Solitaire X 4 into 40 mm, and that is taken up, suction is applied, and the whole assembly is taken into the guide catheter. So you have to bear in mind that the balloon tip was inflated to prevent distal embolization, and you can also know that all these systems are basically connected with flush system while we are doing this. So now I take you as to what really happened. And yes, once this was taken up, you see here are this microcatheter was then unsheathed. You can see Sophia going up. And if you can appreciate, I don't know if you can see this, these are those 3 dots at some distance starting from here, from this M2 level going down. And this is the deployed stent retriever. And this is the Sophia catheter, which is going up with aspiration. And now I'm going to show you how this retrieval was done. This Sophia catheter suction was applied, and this whole assembly was pulled down. You can see that in both these views here. So what happened? So this is the DSA. So you see, this looks pretty good, right? The AP cranial view. And now you will have this lateral view. So this seems to be fine, but this is what we thought as well. On the cath table, at times you miss such small things, but when we closely look, because we have to follow it into the venous phase, what we saw here was some dye that was hanging in. Can you appreciate here in this AP view? You can also find the same thing happening in the lateral view here. This is quite evident. So we thought, we needed to take a better look, and maybe we had done something, maybe there was some occlusion there, some perforation. But when we looked closely, I think this other view came to our help. And in this view, we also saw that this triangular area did not have the amount of vasculature that it's supposed to have. Similarly, in this other view, we could see that after the M1, this M2 becomes, it gives off another branch. This is the inferior branch. This one is the superior branch. And you see this one maybe was occluded. And that's exactly what had happened. So we had to plan it further. So what we did was, we took the wire up again, and this is again another DSA. At that time, unfortunately, since the patient's head is moving, we did not have head stabilizers back then. Now we do have them. So the patient was moving, but we could track this landmark over there, and you see we knew how this branch was taking the curve, and we were able to push the wire up. You can also see that in this lateral view. I may go over there. And then we were able to take the microcatheter up and repeat the same procedure with the aspiration stent retriever. We were able to take the whole system down. This is the Solumbra technique. And I'm just going to show you what happened afterwards. These are the still images. So this is after the first Solumbra that we had done in the inferior branch. And this was the finding. And later on, when we did another one, this whole vasculature, this missing triangle came back. And now we see CT scan. This was the CT. We didn't see any particular finding. No infarcts were picked up back then, but we also knew that there was no intracerebral bleed. But this patient had presented beyond that 4.5-hour window, so thrombolysis was actually out. Straight away, this angiogram, CT angiogram was done, and I'll again take you to the point of interest. So what you see here is this posterior circulation. This is the basilar artery, and this is the distal part. And you see this shows you a filling defect, most likely a thrombus. You can see that beautifully placed here in this view, which again shows you very nicely where this is sitting. And you have this PCA, left-sided posterior cerebral artery, which is occluded. These two here are the superior cerebellar arteries. This one here is the PCA, left PCA. So we had to plan it. We had established the posterior circulation infarct. Straight away, we had planned it. So we took the right brachial axis with a vert catheter. We went up. Just when we engaged the right vertebral artery, we could see disease, along with that, a filling defect. So we decided not to engage here. And I think as Dr. Arsalan, I'm not sure if he's sitting here, he had set the course pretty well for us, laid a good foundation. And he told us, as cardiologists, we always have to find a solution. So we knew what the solution was, and that was to change the axis. So we went right femoral, used a 6 French sheath, used a 6 French destination sheath, which was 9 centimeters long, and we took it up to the ostium of the left vertebral artery. Now you could see the engagement, and this is the angiogram done. So you can clearly see that this basilar artery is blocked at the distal end. Always remember, and this is again the lateral view which shows it, that once you have basilar involvement from proximal to mid-segment, that shows there may be, in 30 to 40% of the cases, there may be some underlying disease. But once it is in the distal segment of basilar, there has to be an element of thromboembolism. And always remember, basilar artery occlusions are quite drastic for the patients, with a mortality of almost 85%. Now, So for this, we again had to plan. Sophia Plus was taken. I'm sure you'll be able to appreciate here that Sophia has been taken up. This was all through the help of a tracking wire. And right now, we are just at the end of left vertebral artery. In the next slide, you see we have taken the wire up, almost crossing the basilar artery into the left PCA and at the end of P1 segment here. The next slide shows the Solumbra technique. So we took the microcatheter, we took the stent retriever, and this was deployed. And then this whole apparatus, I think you can easily appreciate these stents here. The whole assembly was retrieved. And this time, there was no balloon tip catheter, so we had to bring it down back into the destination sheath. And this is the angio. So you see, this part of the basilar seems to be fine, but dye in this left PCA, it comes and it goes. So maybe there was some intermittent filling, maybe there was some endothelial dysfunction we were not sure. At this juncture, we thought maybe we need to, we actually needed to give another run. So we again went up with the wire, took the microcatheter, gave almost another run of our Solumbra, and you can see this is the microcatheter going down here. This is Sophia. Once the microcatheter has been pulled into the destination sheath, Sophia Plus going up as far, as deep into our stent retriever, which was Solitaire X in the same case, 40 into 40, and then this whole assembly with aspiration on was pulled down. I would also like to mention here, according to the new techniques that have been shown, once you deploy the stent, so you can, with your stent, now that we have longer stents, you can go distally, I mean distal from the thrombus by 2/3, and 1/3 should be able to contain that thrombus. And this is exactly what happened here. We took Sophia as far as we could up into the vessel, and it went up almost up till the distal part of P2. Now this was the re-angio. The angio was done again. So we thought we would have things in a better place, but again, you see the same filling defect is there. It comes and goes. And at this point, I think we were thinking that maybe there was something else going on. Maybe there was some competitive filling which was coming from the anterior circulation. So we had to think about all those possibilities. But then again, we also thought of a bailout strategy. And at this juncture, we thought maybe we needed to give it another shot, and this time by giving intraarterial TPA. So what we did here on your left, we took the microcatheter up again, wire guided, and we checked the back bleed along with a 3 cc syringe by giving careful injections. We've got to be very careful here. And TPA, 3 milligrams of TPA were given in the left PCA. And on your right side, you see the microcatheter has been pulled back into the basilar artery, where we gave another injection, 6 to almost 7 milligrams. So total of 10 milligrams were given intraarterially, both in basilar as well as the left PCA artery. And this is the final angio. So again, you see, we can see the basilar, which is recanalized, but the left PCA, it comes, but then it disappears. So this continued with us, but I think as interventionists, we also need to know where to stop. And this is where we called it a day and stopped. And drastically, this patient was intubated during the procedure. This patient was on a ventilator, but things started improving in a few hours post-procedure. And this patient eventually walked out of the hospital. So I'm again, with his consent and permission, I'm going to show you this video that somebody who comes with a GCS of 7, not responsive to any commands, only responds to painful stimuli, goes through a procedure, and in 7 days, this is what happens. Again, our neurologist is evaluating the patient, and he seems to be obeying all the commands. And he's talking fine. There is no deficit, even in terms of his understanding. And this is, I would like to end my presentation. I would like to thank you all for your patient listening. Thank you.
Join us here, Hamza. So thank you very much, Dr. Hamza. You can join us as the panelist. So now I think the house is open for discussion. Any questions that you have? We've got a senior panel sitting here, and I think Dr. Omar Goktekin, if he's still online. So, is Dr. Goktekin online?
Yes, I am. Yeah.
So, Dr. Goktekin, if you have any comments to make, and then we can have questions from the audience and some experts' opinion from the panelists.
Yes. Yeah, Bashir, I'm very happy that in Pakistan, stroke intervention can be done very successfully. I saw excellent 2 cases. They did the latest technique. They did Sonora technique, I think, which is the most effective technique to reduce the time for recognition and of course it's more effective technique than solitaire itself. I'm very happy to see them. Thank you very much.
Thank you, Dr. Goktekin. So, any comments from the panelists?
Omar, this is Sohail Aziz. It was great to listen to your talk, and we really amazed at the pioneering work with RIC and Dr. Asim Javed and with the patronage of General Azhar Kani and now Anjum Jalal Saab. They've done amazing work. It's so rewarding, and they've put in so much hard work in trying to promote this technique and trying to further this specialty in the cardiology field. It's just, I think the real issue here is the cost which is involved. It's not just the skill set. Skill set, of course, is very challenging, but the amount of cost which gets involved, I think that's what's happening, is that the neurophysicians and the interventional neurologists or whoever is interested in this intervention, most of them are in the private sector, and they do not have access to the cost implications of an acute stroke because the amount can be colossal. I think I heard that Shifa charges about 12 lakh rupees for a stroke intervention. I'm not sure if that's true or not, but so it's only big centers like RIC and NICVD and PIC which can get involved and provide this service. Otherwise, this amount of cost implications cannot be supported by any private hospital or anybody else. But you've done amazing work, and you've really taken the field ahead, and I'm really pleased for you.
Thank you very much, sir. Just to make a comment on the cost.
Asim, may I add a point from here?
Sir, please.
Asim, may I add a point from here?
Yes, Dr. Bilal.
This is Dr. Bilal over here. Dr. Omar, we have got Bashir Hanif over here also. Good to see you again after so long, and sort of welcome to Pakistan from this side. There is always this debate about a lot of things going on. What was the transition time for you from a coronary worker to go into a CV, into the brain territory? How long did it take you to acquire this skill set?
Yes, very good question. I'm very happy to say that I have, young, fresh cardiologists in my lab all the time, and I teach 2 of them this technique, and they learn very fast. They learn. I see. Maybe I do. We are a little bit senior cardiologists, right? So we do a lot of things, training, many things. Maybe it could be for us to learn fast. That's understandable. But also, what I see, I was very happy to see it. My fellows learn it very fast as well. That's why I'm saying that this technique is not that difficult. I teach, for example, at the moment, my 2 fellows, could do this intervention very successfully after, I would say, 6 months. Maybe they attend, each of them 10, 15, maximum 20 cases, and they learn how to do, they learn tips and tricks. But both of them used to do carotid intervention. This is very important. First, someone should learn how to do carotid intervention. For me, at least 50 cases, right? Carotid intervention looks easy, but it has some tips and tricks, some difficulties sometimes, especially, engaging carotid artery. For stroke patients, we have elderly patients, they have sometimes type 2 or type 3 ARC. So we have to be, we have to learn how can we access those patients. So in my practice, I could say that learning and teaching of this procedure is not difficult. I don't know. I want to ask Asim Jawad, because I know that the Asim is exactly the same position in Pakistan, since he started as a first cardiologist, if I'm correct, in Pakistan. And I'd like to learn his opinion as well regarding this learning and teaching process for this acute stroke intervention. Asim, what do you think? Am I right? Is it so difficult to teach and to learn?
You're very right, Dr. Goktekan. And I think once you start doing it, you realize that the work that the interventional cardiology does in coronaries is actually quite difficult as compared to what we have to do in the stroke intervention. It's a much easier intervention to do, very rewarding. But of course, there's a learning curve involved, which is not big enough for senior interventionists. Anybody who's doing a lot of coronary interventions, I think it's not a difficult thing to learn. And I'm very pleased to say that 4 of my interventional cardiologists at Rawalpindi Institute of Cardiology are now actually doing these stroke interventions. They've been doing these cases with me. And now that I was attending this conference here, even last night I was here, my team did independently stroke intervention. They were able to help a 40-year-old lady, and she's back to her normal self. And they've done it all independently. So it's not a big learning curve, but I think we need to take an initiative. It's difficult to get out of our comfort zones. Otherwise, it's not difficult to learn. I totally agree.
Yes.
Well,
and I will add to this. General Suhail very kindly said that there's a lot of cost issue behind it, and I totally agree with him. There is a lot of cost issue, but when you're talking of things like TEVI and EVAR and all of these things, we can do this on a national basis. We can have a fund, and gradually this thing can be built up. I know Bashir Saab doesn't like the idea that people are doing it sort of unguarded, and I totally agree with what he's saying. It should not be done unguarded. What we need desperately today is that we need to develop these programs which may be run by cardiologists who want to shift their lines, shift their gears, but a program must be made available because this is in the national interest, and that is exactly what Umar has seen.
See, I absolutely agree. And I think Asim is doing a marvelous job by having these sessions and trying to really go to different places. He came to Karachi a couple of times, and we had a lot of our junior people who were there in that session, and everyone learned a lot. And we started our program at Tabba Heart Institute similarly. We had discussions with Asim. We again had a lot of theoretical knowledge we had to go through, obviously, which Umar mentioned earlier, anatomy and all the basics. But then Asad and myself started doing it gradually. Asad took the initiative, and although we haven't done that many cases so far, and we are in the private setup, cost is a major issue. And I was actually going to ask Umar, I know all these equipment which is available, and a lot of Turkish companies are making, I think, some stuff which I don't know, maybe a little cheaper, and that might help. But maybe we start getting some Chinese stuff that may be a little cheaper. The other option is that I don't know. Again, that reusing certain things. That is one possibility that can cut down the cost, especially the larger guiding catheter or wires. Those things can be reused and make that cut down the cost. Otherwise, in private sector, it's going to be very, very difficult.
Bashir, to my opinion, cost is really issue. We have to mention that. For example, in our practice, rarely we use, Solubra technique because of the cost. So in our practice, routinely, and we rarely use duct catheter as well. That's also another cost. I don't think we have to use Solubra technique. I don't think we have to use duct catheter for each patient. What we do to reduce the cost, we use, of course, microcatheter. We use stent retriever with balloon guiding catheter, right? So with balloon guiding catheter, we can do aspiration while we retrieve the Solumbra, for example.
The question is about can we recycle this equipment? Can we recycle the equipment?
Yes, we can do. We can do, to be honest. We can do microcatheter, we can do solitary, we can do guiding catheter. We can recycle 3 of them. Yes. Yeah, I have to say that. Yes. Otherwise, it will be very difficult.
How frequently do you?
So if I can respond to the cost question as well, I think we need to look at 2 aspects. One is when you do angioplasty, coronary angioplasty for 2 vessels for symptomatic relief, you're spending around 2.5 to 3 lakh rupees. And this is just symptomatic relief, circumflex, RCA. Look at the difference in what you are intervening on a paralyzed person who would either die or would remain paralyzed for the rest of his life, and the amount you actually spend on the intervention if you are using all the equipment, doing the Solumbra technique and all, it's not more than 5 to 6 lakh rupees actually. What the cost that General Sohail was adding on to is the cost of ICU stay and all that stuff. Otherwise, the actual equipment does not cost more than 600,000. The other thing is you can really reduce this cost. For example, the balloon tip guide catheter costs around 95,000 rupees. You can use a destination sheath 6 French 90 centimeters in place of that. That would cost around 45,000. You want to reduce it further, you can go ahead with an 8 French multi-purpose guide. The cost comes down to 6,500 rupees. You don't want to use Traxxas wire. When we don't have the dedicated neuro wire, we use a BMW wire. So that's fine. You again cut down the cost. You don't need to use stent retriever in every case. You can just use, that is where the actual cost is. So like in our Rawalpindi Institute of Cardiology, since I'm training people, I go ahead with Solumbra in most of my cases because I want them to learn deployment of stent retrievers, Sophia Plus at the same time. And we are lucky enough that our executive director is supporting us and he's giving us the equipment. When we started off initially, I'll come to the ETO part now. So when we started off initially, we had a problem of delivery of equipment. And after a few cases, we didn't have any equipment. So we were doing ETOs. And all of this stuff can be ETO'd. And you can do at least 2 to 3 cases with this ETO equipment. So there are ways to cut down the cost. It's just the will that needs to be there. There are ways to deal with it.
And as you say, the reward is so great. I think that justifies that we must go for it. Let's ask Dr. Salim Virani, Sili is around. What is happening in USA? In your Baylor Hospital, how many interventional neurologists do you have?
So for us, right now where I'm at Baylor, almost all of it is actually done by interventional neurologists. The cardiologists are not doing that many. And it's likely because we have those trained interventional neurologists and some interventional radiologists who are doing it. But I mean, there are institutions even in US where interventional cardiologists are doing. So I think it varies based on who is available. I think there are a lot more trained people here compared to what we may have in Turkey or in Pakistan. So here, I think most of the interventional cardiologists probably stay within the area of coronaries, get into peripheral, some do carotids. Then in the acute stroke setting, it's a very, very small chunk who would get into that.
Assalamu alaikum. I'm Dr. Harun Babar here. Well, this issue has been addressed several times in our meetings and in our societies. I think it is high time that all the institutes, especially at least the institutes, because they've got all the basic facilities available. Either it is Multan, either it is Lahore, either it is Karachi or Peshawar or those. They should start this program because cerebrovascular accident is more trauma than a coronary accident. At least it is equal to that, or it may be a more. So it is not only a life-saving procedure, but you are saving the whole family, because the person is paralyzed. His whole family suffers. Himself he is suffering, and look at the cost effectiveness. And the other thing which has been pointed out by our learned speakers and yourself as well, that ETO can be done. And if ETO can be done, I think we should start it. Unless you start it, it will go on like this. It will be a slow process in every.
I think we should be very careful when we mention ETO, and because with the health commission going in, one has to have a legal coverage for it before one can offer it to people, because this is a very sensitive issue, how it's used and how it can be abused also. So I think as a society, as a specialist group, we have to address this and take it up legally before we can start recommend using it as a recycled.
I agree with you. But this has to be discussed on the panel.
Well, I have actually, we are working on that. We have a special, PSIC, who is working on the CTO and come up with the document. Actually, Professor Afizullah is the chairman of that committee, and we have already devised the guidelines, and we are going to submit it to our council. And then we have sent those guidelines to the Sindh Healthcare Commission. And
we were having very much deficit of the equipment. Only one vendor was available. So we were using at that time, after these guiding catheters, wire, we used to ETOs and regularly. And I think about first 50 or 70 procedures we did like that. And then after that, we had 2 or 3 vendors, and then we used to cut the equipments. And nowadays everybody knows that nobody uses here the ETOs in the coronary interventions.
Umar, what's the status in Turkey? Anyone regarding a reuse or ETO?
Sorry, I couldn't understand the question.
What's the status of ETO or reuse of the equipment in coronaries in Turkey? Like reusing the equipment, re-sterilization of the equipment.
Asking, like do you re-sterilize equipment in Turkey?
Yes. Normally, we are not allowed to do it, but in some specific catheters, like microcatheters, sometimes extension catheters, in certain device, yes, we do. But it's not that routine. We don't, for example, do recycle for balloons. We don't, if it is quite expensive, so sometimes we do.
So I'm very glad to see that Pakistan Cardiac Society, Pakistan Society of Interventional Cardiology, Cardiology Update, and Coming Pakistan Live, we've got a session on stroke intervention. That's very heartening to see that we've got a lot of support from the societies. Dr. Anjum Jalal, would you like to make some comment?
Well, that's almost covered everything. The major issue here under discussion is the cost. And being head of the institution, I think I can make a few comments on that. The cost actually follows the market dynamics. If you are using 2 or 3 cases with poor outcome, nobody is going to give you the money. And the gadgets you use will be very costly. If your numbers are big and the benefit to the society is very high, the cost comes down, the prices come down, the vendors start finding confidence in the market, and at the same time, the governments, the funding organizations, they also develop confidence in that. We have seen that in 2007 and 8 in government sector, anybody who needed more than 2 stents was referred for surgery. That was a common practice here. But now, after starting the central procurement, we have brought the prices down to the rock bottom, and now we are doing multi-vessel stenting without considering the cost. I can see the same thing happening in stroke program. And when we started it, I remember it's nearly now 5 or 6 months. When you wanted to start it round the clock, and free of cost for everybody, my fears or my anxiety was not about the cost, it was the outcome. I just wanted to have the assurance that we are going to have reasonably predictable results, and that would actually bring the confidence of society into that and the rest of all the stakeholders. And it had worked very well. Who would stop a good thing? I mean, in any cardiac institution in Punjab, the budget is huge. I never had any limitation in providing the budget for any such initiative at all in last 13 years, working in heading 2 different units and working in 3.
So,
Government never stopped us providing the budget. We are using
excuse me, can people stop talking amongst the crowd, please?
we are consuming more than 3,000 stents, all free of cost for the patients in a year. And we are doing more than 10,000 angiographies. If we add another 300 cases of stroke intervention, that would not bring any extra burden to the budget of my institution. And even if the government refuses, we have enough indigenous resources from our own receipts that we can sponsor this program. I think the most important thing is to have a team who are naturally gifted people who are compassionate and who believe in relieving these problems from the society. Once you have that kind of person who is heading and you have the team, then the budget and the cost can be managed very easily. Well, I'm extremely happy that you are doing so well, and we are happy that RIC is producing good results. Thank you very much.
I just wanted to add one thing. Your point is very much valid because I recall once again in NICVD that we started the primary angioplasty and we used to have a debate in our faculty meeting. And our director, he used to say, nobody is going to come after 2 o'clock. So why is going to come? Because we have to pay something. And then the time came, we started to come from 8 to 8 and then round the clock we were doing over there. And then later the time came when the Sindh government said that all the procedures will be free of cost in the whole province. So the money is there. And when there is a will, there is a way. So government also comes. When they see the result, you can convince the people, the money comes. So it is from the NICVD experience that I really have seen.
I think
Yes, sir.
the efforts
Awesome,
of-
great job.
Thank
and
you,
keep
sir.
it up.
Thank you, sir.
the efforts of RIC need to be commended for the work that you are doing. But what we need to actually create also is an awareness amongst the public that they should, like, for example, with the heart attacks, that we were able to do so when patients were able to come to the hospital within that specified time so that intervention could take place. So if the patients can be made aware of it, that if they get these symptoms, they should reach a nearest facility, apart from what Harun said, that the different there should be more institutes having this program so that the patients can come over there and they can be intervened upon. Unless and until we have that program of awareness amongst the patients, amongst the general public, that they should reach those facilities, I think the cost will not be able to come down, because if you have more cases coming up, the cost will definitely come down.
So you made a very valid point. Just to add on to it, since we started a 24/7 program, we are now receiving almost 6 to 10 stroke patients per day. And the unfortunate part is that most of them don't qualify because lack of awareness, lack of education, they reach us late. So almost 1 after 30 patient qualifies for intervention. So now we are making an effort, and Dr. Anjum Jalal is taking up the case with the government to give us an ultra fast CT, which is a 540 or a 640 slice CT, because with that we'll be able to do perfusion scans of the whole brain. And with that, the therapeutic window would then go from 6 hours to 24 hours. So even if the patient reaches us within 24 hours, we'll be able to intervene on many more of them. Because till the awareness is there, they are not going to reach in time.
my knowledge, that what is the role of a health card, which has been issued in various provinces, and each 10 lakh rupees are reserved for each family. If a productive person of the family can recover from that health card money on this procedure, they can be benefited.
I can speak for Khyber Pakhtunkhwa. It has done an absolutely wonderful job in KPK. We are putting 2 or 3 stents routinely, totally free of cost. And at times, even if 4 stents are required, with their permission, we can put 4 stents as well. Cardiac surgery is being done totally free of cost. There was a time when we used to convince patients that you have got a patient, a relative who needs angio and angioplasty, and they would say, we don't have any money. And now patients are coming to us, sir, I think we should go and get a stent for them. So there are lots of patients. I think it has absolutely revolutionized the way we are practicing at least cardiology in KPK. So if with the same argument, if you can do cardiac surgery, if you can put 3 stents, why can't we do stroke prevention as well?
Sir, I just add on to that, because we're doing primary prevention 24/7, but we try to incorporate that stroke intervention as well. But I personally think the main hindrance is a teamwork. You need a radiologist, facility for radiology, you need a neurologist. So a teamwork needed, which is really causing hurdle in this program to go beyond that just thoughts. So that is needed, that it's not a pure cardiac center who can be doing stroke intervention 24 hours, unless and until you have a team which is there, and this team should be there for 24 hours as well to give you their inputs in that. And that's the main issue, I personally think.
But it can be resolved by performing in tertiary care hospitals, where the services of neurologists and every specialties are present.
So I think with this we come to the end of the session. I'll request Dr. Sohail Aziz to give his concluding remarks, and then we close the session.
Thank you, Asim.
Sorry, before Suhail, Suhail.
No, I think, Omar, you should give some concluding remarks before we say something. We always love to hear what you have to say.
No, thank you very much. But I'd like to congratulate Asim Jawad. You know, I follow him and I saw how he has good effort for stroke intervention, not for only Pakistan. I know what he did for Pakistan, but he also worked for other country. He teach for other countries as well. So I really admire his what he does, and I thank you very much, Asim Jawad.
So a hand for Asim.
Intervention, yeah, in our community, in intervention cardiology community, and also I am very agree with the last comment a friend did. We have to have very good team for stroke intervention. For us, you know, we are in this business. We are technicians. We can open the artery very nicely. We can do that. We trust ourselves. We can open the artery, but before and after, I don't think it's our work. Selection of the patient is important. I think it has to be done by neurologists. We have to be very good relations with the neurologist, and especially after procedure, we have to leave our patients to neurologist's hands. I don't think at the moment, I'm saying for us, you know, because we are learning now, but maybe after some time, you know, it will change. Maybe there will be a different way to do it, and some cardiologists also could do some neurologists for, I don't know. But at the moment, currently, I think we have to do procedures and we have to leave the patient, our colleagues, neurologists, I think. That's important. We have to be very close relations. You know, we cannot say ourselves as a stroke physician. That's something totally different.
Thank you.
And also,
Omar.
I want to say that I believe that we are a bridge now at the moment, maybe next 10 years. I believe in 10 years, neurologists will learn how to do intervention and they will do it. If they do it, we don't have to do it because we have lots of work to do. Why we do interest this? Because nobody do it. But somebody has to treat us. If something happened to me, please, somebody help me for my brain. That's why we interested this work. That's why we'll do this. If intervention neurologists will learn it, they stop to do it. I don't mind.
I think, Umar, that's very well summarized. I think the amount of enthusiasm and the opportunity we have as a community is immense. And there's so many of us who are so skillful in this procedure and who are so eager. And I'm sure with there's Will and people like Anjum Jalal there who will promote our case. I think it's just we need to start educating ourselves so that by the time the funds are available, we're all well educated. So I think, Asim, you need to do these training sessions more often. Maybe have online and keep on repeating it, hammering it in. And I think by the time people like Anjum Jalal get the funds going and the Sehat card gets this thing approved, we are trained for it and we can build on that. So it's I think really poised for it. And like Umar said, that eventually I'm sure there'll be enough radiologists and neurologists who'll be doing this intervention. But till that time, we'll have to fill up the gap. And I think we have enough, like we're talking about a cardiovascular institute. I think if you take on these ischemic limbs, you need to really have to expand the cardiac institutes. There's so much limbs at risk. If you start taking them in, they'll occupy half your beds. So I think that has to, in fact, I think the natural leadance in a country like Pakistan is that cath lab facilities are so scarce that any procedure which has to be done in a cath lab can be focused around a cardiac institute. But as you've got radiologists doing it, you've got vascular surgeons doing it. It's all a question of who gets trained. So once you're skilled and you have access to a cath lab, it's all a question of certifications. So who gets certified for what and who gets trained for what? It's a great job, and I think there's a great future. And we as a community should really get ourselves geared up for this procedure because it's here to stay and we need to learn the skill.
So I can still see Dr. Virani with us online. So may I request Dr. Virani to give his concluding remarks and then we finish the session. Thank you very much.
Well, I think, Alhamdulillah, a lot of great work. Very heartening to see this wonderful work happening. I think as somebody who's prevention, I would like to echo two comments. One is that apart from working on the acute intervention, I think we need to look at it from the prevention aspect as well. And I think a comment was made. We don't have any system in our country right now to take care of hypertension, lipids, diabetes, physical inactivity, or our diet, which are all major issues. So I hope that as these programs develop, of course, acutely we need to take care of the acute stroke patients. But if some prevention programs can be developed around it, and the second is that when you all are having those discussions with our government and in your own little circles, if we can do something to work on the patient side of things as recognizing early symptoms as well, exactly as you mentioned, I think you said you're doing 1 in 30 patients who are eligible. So making sure that our patients are presenting early, just like our acute MI patients, I believe we need quite a bit of work in that space as well. Our patients recognizing the symptoms and then presenting early on so we can actually provide the service that we have. So that's more of a request that as you all are looking at these programs in our country, if we look at the prevention side of things, as well as the messaging to our fellow countrymen, so they can utilize it by presenting early when having these acute emergencies.
So I thank all the panelists and the audience for staying so late. So thank you very much, and join us for dinner and enjoy the rest of the evening. Thank you.
नहीं तो वज़ू भी मैं करके नमाज पूरी करके आ रही अब मैं मगरिब इशा किसी को हाँ ना